Everyone, welcome to this month's installment in the Teaching Value in Healthcare Learning Network. Here we come together with leaders in the field to get practical and tangible advice about developing engaging curriculum and health system innovation to train a new generation of healthcare providers. This is a joint project between CASA Care and the ABIM Foundation. We created this learning network as a place to share ideas, education materials, and strategies in an open forum, hoping to spread the word across the country and, as we see today, Canada and elsewhere. Our goal is to discuss ways to get started, implement, and sustain feasible innovations. And so you see there's three components of our learning network. Monthly webinars with on-the-ground and national leaders, as we'll hear from today, discussion groups, and also tools for educators on our shared Google Drive, where we can share educational materials, publications, and presentations. Today, we will have a conversation with Dr. Todd Lee, who's an associate professor of medicine at McGill University and director of quality improvement at Royal Victoria Hospital. My name's Chris Moriades. I'm a hospitalist at UCSF, and I direct our Caring Wisely program here. I'm also the director of implementation for CASA Care, and I'll be moderating today's webinar. Today, Dr. Lee is going to share some insights about a program he started as part of his MPH at Harvard, and he started it at McGill. And he'll tell us about how he worked with his with residents to help them decrease unnecessary antibiotics. As always, we like to make the session an interactive discussion and ask participants to submit questions online. We're looking forward to a great discussion. So Todd, I'll let you take it away to describe a little bit about your program and how you got started in this.
Great. So this is a project that started somewhere around 2011 when I was initially being recruited to join faculty here at McGill. I came to a grand round session here, and before me, some colleagues, Drs. Lawrence Green and Dev Jayaraman, had started something really interesting with the residents by making them officers of quality and perform regular quality improvement audits for a variety of things on the clinical teaching unit. For example, Foley catheters or intravenous fluids and DVT prophylaxis. And they presented a 2-week pilot where they had the residents look at their own antibiotic use in a completely unstructured way and demonstrated that even by having them start to look at their antibiotic use, there was kind of a Hawthorne or observer effect in terms of diminishing overall utilization. And so born out of that, and then around the same time, the CDC put out their Get Smarter for Healthcare campaign, where they started talking about the idea of antibiotic timeout. I thought about kind of merging the idea of the antibiotic timeout with the audit culture that had been established at that time at the Montreal General Hospital, and to really take it and put it in a relatively rapid to use, structured way that kind of paired education and a web-based tool. I mean, I guess it could have been paper, but a tool for the residents to complete. I was very into checklists at the time, having read Atul Gawande's book and having had the opportunity to see his lecture while I was doing my master's. And so what we did was we created a curriculum. This curriculum is given every rotation. Our residents rotate through once a month. They have a complete changeover. So this curriculum was given at the beginning of every month, and it was based on our local antibiotic utilization guidelines and our local epidemiology for the type of things that are admitted to our clinical teaching unit, and kind of a priori based on our collective discussions between the general internists who work on that unit, the director of infection control, and I'm actually cross-appointed to the Division of Infectious Diseases. We thought about what our priorities should be for this education, and so we created a 30 to 45 minute kind of interactive discussion, kind of didactic session that introduced a lot of our institutional guidelines and kind of justified them and took the residents through the process. Not surprisingly, very common things were on the menu, including community-acquired pneumonia, cellulitis, and my personal favorite, urinary tract infection. And we kind of coupled, going towards the guidelines or helping people choose guideline concordant therapy with introducing the concept of antibiotic stewardship, which even though it's been around for a long time, hadn't really propagated through into the curriculum for core medicine, core internal medicine residents. And just here in Canada, all residents will do 3 years of core internal medicine before ultimately doing a subspecialty. One of those subspecialties is general internal medicine, which is an additional 2 years. So we get all core internal medicine residents and give them this as they come through the clinical teaching unit. And so we introduced the concept of stewardship and why it might be important, and kind of introduced, sometimes for the first time, although now we've been doing it long enough that it's not the first time, but sometimes for the first time, the idea that antibiotics have harm. Okay, so it started with this curriculum, and the curriculum was paired with the tool. I've made on the Teaching Value and Learning Network website, there's a link, I think, to a demonstration electronic version of the tool and to a paper version of the tool. But basically, we just decided amongst those of us who've done antibiotic stewardship using the method prospective audit and feedback, what were the kinds of thought processes that we would use in being expert adjudicators of antibiotic use externally? And how can we prompt the resident physicians to do the same thing as they were reassessing the antibiotics of their patients? And so we created this toolkit, which was kind of a balance between difficulty, ease of completion and length of time of completion, but being thorough. And we instituted, a policy that the resident physicians, the senior resident physician, would go through the antibiotics of all of their patients on antibiotics twice a week. And they were pretty good about doing that, and it would take about half an hour, and they would sit down with their list of 15 plus or minus patients who are on antibiotics and go through the thought process of, well, why are they on antibiotics, and are they still the appropriate ones, and what kind of changes should I make? And so initially they started doing that, and then at the end of every period I would tally up how they were using antibiotics for specific infections and give them some targeted feedback about certain areas where they were still overusing or misusing antibiotics. And that often was an unnecessary broad spectrum, but many times at the beginning related to the treatment of asymptomatic bacteriuria. And essentially that's what we did. Lather, rinse, and repeat. We did that process every month for the period of study, and the paper was published in 2014 using data up until the middle of 2013. So we had about 18 months of data when we did the paper. And now we've been running the same project in all 4 of our clinical teaching units since the beginning of 2013. So we're 3 years in. And the format really hasn't changed. It's a similar format of introduction, use of the tool, and then tailored feedback for that individual group. As I mentioned, it took the residents at the beginning it took them a little longer. Now it takes the residents something on the order of 15 to 30 minutes, depending on how many patients are receiving antibiotics, to do the audits. They do them twice a week. And, it takes either myself or someone else who volunteers to give the introductory session, the half hour to give the talk. And, there's a minimal back-end data preparation in terms of preparing the feedback session and giving the debriefing. That takes about half an hour. So that's what we did, and we ran essentially the same project throughout the 18 months of the study. Now, kind of a priori, we decided that we wanted to evaluate quantitative antibiotic use to really demonstrate that there was a difference quantitatively. And so we limited ourselves really to 4 targeted groups. We looked at parenteral vancomycin, of which, because our prevalence of MRSA is so low here by comparison to other centers, is subject to a lot of overuse. And we looked at intravenous piperacillin tazobactam, which is essentially a vitamin added to the water of most patients admitted to our hospital, unfortunately. We looked at the respiratory fluoroquinolones because, we're still suffering up here in Montreal with, the vestiges of that huge outbreak of quinolone-resistant Clostridium difficile that was described by Vivian Liu and others in around 2003 in the province of Quebec. So we really want to try and minimize quinolone use. And then the carbapenems, because we're very fortunate we don't have a carbapenem-resistant Enterobacteriaceae problem, touch wood, yet. And so we wanted to minimize the use of these agents and try and preserve them. So those were the four kind of objective outcomes that we looked at, and we used a technique called interrupted time series to evaluate for change associated with the intervention. And really what we were able to show is that there was a statistically significant reduction in the utilization of fluoroquinolones that happened over time and not immediately, and kind of a more immediate change in the use of carbapenems. And because at the time carbapenems were the most expensive antibiotic we had, there was a substantial cost savings, which I think we estimated at somewhere around, excluding the carbapenems, around $60,000 to $80,000. Which wasn't bad when you factored in essentially 12 faculty hours of work per month and 4 to 8 house staff hours to conduct this program. So the results were really encouraging. And in taking it out beyond the trial aspect of things, the last time I was able to look at the data quantitatively, we've actually seen a reduction in everything with the exception of piperacillin and tazobactam, which at least has stabilized instead of escalating use that was happening before. And so that, in a nutshell, is what what we were able to demonstrate and how we did it. Some of the major challenges in longevity have been that there's because house staff are always getting reintroduced and new. The curriculum needs to be maintained. We've demonstrated sustainability, but it's not without concerted effort on my part and on the part of Lawrence Green and Dev Jarayaman at the Montreal General Hospital. Our training program is such that house staff will rotate between hospitals. For the most part, they spend most of their time at their base hospital, but they'll go out to community hospitals or to other hospitals with different antibiotic prescribing practices. And so they come back with different habits that have to be restructured, shall we say. And so longevity is a little bit of a challenge. The medical students come to this, and the junior residents have been coming to this. This is not just this is interns and residents and medical students. And so I am pleased, to look at things now 3 years into the process. There's much less inertia to overcome, and I think the dose effect of boosting the effectiveness of the intervention is much stronger now. Certainly, our usage of, for example, respiratory fluoroquinolones for community-acquired pneumonia has substantially decreased, and that's kind of a long-term change. But I'm fairly confident that if we stopped using the program, that external forces would again, change the prescribing behavior.
There's so many good things that I want to highlight that you did that are just incredible. You took a national imperative, the CDC antibiotic timeout, merged it with sort of your local culture and practices, and looked at what was really going to be effective. Used a multifaceted program. And also then sustained it by championing it. I was curious what you think is the most challenging part of that, or for others who want to pick up your program, what is it that you think is going to be the most difficult thing for them to use this program and make it generalizable?
A couple of, so first of all, you need a very, I think, not to underestimate the point of having a very dedicated champion that not only comes in and gives the initial talk, but really takes a vested interest in the success of the program. And we were fortunate to have that now at all of the sites that are doing it. I think that making sure to set aside the time to have the boosting effect is important because of those external forces, both in other rotations and in other specialties the house staff will go through. One of the major challenges is also getting buy-in. I think we were very lucky in that the directors of our unit were all very on board with this enterprise and believed in it. And sometimes it takes a lot to convince academic faculty to change their own antibiotic prescribing behaviors. And one of the things we have seen is that there is a faculty-to-faculty variance, despite the fact that the residents are doing this. So the residents' practice has homogenized a little bit, but the faculty practice is a little bit different. And so, in recognizing that there will be faculty differences and coming up with some plan to compensate for that may be important to making it work in your institution.
And just to be clear, did anything bad happen that you heard about patients who antibiotics got stopped too early, or any adverse events that actually came about?
Yeah, it's always a concern in any antibiotic stopping intervention. There's always a concern that you're going to stop in that one patient. We tried to elicit a number of different outcomes that could be related to harm. For the purposes of the clinical trial, we looked at ICU transfer rates for sepsis, which did not change before or after the intervention. We looked at the development of C. difficile, and unfortunately we were at that time underpowered to demonstrate a reduction in Clostridium difficile. And we looked at length of stay, and we looked at in-hospital mortality. Length of stay and in-hospital mortality and ICU admission didn't change, and C. difficile numerically went down, but we were underpowered to show a statistically significant difference. Looking now, if we were to compare our rates now in C. difficile until before the intervention, they're definitely down, but there have been a lot of other things that have happened between then and now, including to a brand new hospital.
Which reminds me, just another thing to highlight that you did that was so important in this work is you robustly studied it. I mean, you used an interrupted time series analysis, studied this robustly, and published it in Annals, which is actually where I came across your work. So it is just showing the power, even as we're trying to do more crowdsourcing and doing this learning at work, there still is a real power into studying things right up front and then getting it out there into the medical literature where I think it can have an effect, and where you can kind of come to affect changes elsewhere. So I think that was really important and something that sometimes gets looked over in all of our drive to improve things as quickly as possible, is the importance of studying it and getting it out there.
One of the things we believe here as a center is that quality improvement needs to happen, and we need to do things at the point of care to do the best we possibly can as quickly as possible. But there are also valuable learning and research opportunities paired with that. So anything we introduce, we try to come up with some objective framework for evaluation so that we can publish it.
Yeah, and I'm getting some questions texted me from Reshma Gupta. She mentions a great point, which is, audit feedback is not received well the first time around. Oftentimes when you say, we're going to show you your practices and feed that back. So how did you overcome this? And have you done audit feedback with faculty members, showing them their antibiotic practices?
So one of the sales points of how I sell this to the residents and to the faculty is that we're doing audit and feedback internally. It's a member of the care team. They know the patients. They're just using the tool, which is a little bit different than if we had someone, either a trained pharmacist or someone from infectious disease, come and audit our work. And so I think internal medicine residents particularly, and internal medicine faculty, are very receptive to the idea that we can do a good job on this. We have done one or two periods where we had an external auditor look at our practices and look at appropriateness, and actually our appropriateness scores quite well when we have an external auditor come out. And one of the things we have done for our faculty here on various time points is create a faculty report card of various quality measures, comparing them to the median performance of their peers, and antibiotic utilization is one of those things where we've fed back to them, their proportion of fluoroquinolone use compared to their collaborators or their colleagues, and that's been an interesting experience. We don't get a lot of objective feedback of how we practice as compared to our colleagues, so it's definitely been an interesting experience to provide that.
And another great question I'm getting here is, how do you counteract teaching on antibiotic practices at other teaching centers without putting those attendings down? Right, that's a careful thing to do.
Yeah, it is. When you're opinionated about anything, it can be very challenging because house staff they're so good. They want to learn. They want to please, and so they will emulate people in whom they place a lot of clinical faith. And so it is challenging to have them unlearn some of the things that they've learned. In a non-negative way. We focus mostly on saying that these are our institutional guidelines, and other centers may have varying practice and institutional guidelines. And I talk to them a lot about the process that is behind why we make our guidelines that way, and some of the rationale for why we choose those antibiotics for community-acquired pneumonia at our center. And I focus and emphasize most on why we do things our way as opposed to why we don't do them someone else's way.
Right. Yeah, that sounds like a great strategy to try to get around that. So that you mentioned the tools are available on our learning network, so they're freely available for anybody. Maybe describe the tool itself a little bit more so that people know what's in it.
Sure. So available is the slide deck that I've been using at the beginning of the month. There's also a PowerPoint where I that I made for the annals where I kind of narrate how to use the tool, slide by slide or page by page. The tool is just a Google form, anonymous Google form, and it's just a series of check boxes and drop downs that take people through the thought process. Record it in a spreadsheet for me so that I can look at it later. The link that you have is a version that people are free to. It's released under the Creative Commons license, so they're free to take it and do what they want with it as long as it's attributed and it's not used commercially. And it's probably a decent starting point for people who would want to build in specific things for their hospital. We built this very generally for the type of infections we admit. And certainly it's by no means a perfect tool and could certainly be improved by other people. So both the paper version and the online version are free for people to use, implement if they like how it works, or modify it for their own purposes.
Yeah, no, and thank you for making those available. I mean, that's another really great part of this program, which is you created these things and let it out there and open to folks adapting it and using it. I assume you'd love to hear from those people if anybody does pick up this program or use your tool and hear how it's been being used.
Oh, absolutely. On the page is my email address on the major web page of the demonstration version, and I'd be more than happy to work with people for kind of customizing it to their own needs and to know who's using it, and maybe there's an opportunity for multi-center collaboration. I was telling you before, Chris, that the first Thursday Hangout, Rob Fogarty was talking about eye care, and I was so jazzed by his presentation that I reached out to him by email, and then one of my colleagues, Emily McDonald, met him at SGIM when it was in Toronto, and now we've been doing some of the eye care sessions here at McGill and comparing to some of the American centers, and it's been really, really cool. So I would love, if anyone was interested in doing antibiotic self-stewardship, to collaborate with them on projects of various sizes, even just descriptive.
Thank you so much, Todd. That's the most satisfying feedback for this learning network. That's exactly the type of interaction that we were hoping for this to achieve. So to see that come together, and hopefully this podcast that will go out will have a similar effect on others. To bring you together and collaborate. So I think there's no better way to end this session than thanking you for coming on and sharing your program, which I think is a really impressive program. There are very few things that I think are more impactful than trying to get our resident physicians and all physicians to decrease antibiotic overuse. As you point out, the harms are clear. It's a good practice of the way you did it, where it really supports self-reflection and professionalism, and using all the different multifaceted tools of audit and feedback, really, really impressive. And so thank you for sharing your example and for giving us tools so that we all can hopefully take that and run with it at our own institutions. So reminder of everybody that the tools for the educators link is off the main page on the left side. It will link you to some of Dr. Lee's tools and other materials needed to use these resources at your institution. And we want this community to be yours, so please help us continue to contribute to the Learning Network and let us know what resources will be most helpful to you. We invite all of you to join us again next month on the third Thursday for a 30-minute session. And we will be making these available also now for audio podcast download shortly, so you can listen to these on your way into work, on your drives, and hopefully we'll have more dissemination of these fantastic discussions that we've been able to host. So thank you, those of you that joined us, and have a good rest of your week.
Thanks, everybody. Bye-bye.